It is viewer's choice. Call in or email your questions on any health topic as we open the doors to Ask Anything tonight on Call with the Prairie Doc.
Good evening and welcome to On Call with the Prairie Doc. Tonight's theme is Ask Anything, where we work to answer whatever medical questions you may have. Our Ask Anything shows always brings in many calls from you at home, and we enjoy the interaction and do our best to provide you with honest, science-based answers. I'm going to challenge you. See if you can test our capacity, Bill. Let's see if it works out. They can stump the doc tonight. Joining me tonight to field your questions is Dr. Bill Miller, the governor of the American College of Physicians in Nebraska. Bill, tell us a little bit about what got you into medicine, and what in the world is the governor of the American College of Physicians? And why are you here? You're from Omaha, Nebraska.
Yeah, well, it's not raining here. It's raining in Omaha. Well, Rick, I grew up in a small town, as you did, and my father was a family practitioner in that town. So I got to know
in Nebraska.
In Nebraska.
Yeah.
Ainsworth, Nebraska. Sandhills of Nebraska, just south of South Dakota, by the way.
Right.
Lots of interaction with athletes from southern South Dakota.
Yeah.
And I got used to the lifestyle, and I saw how much he enjoyed doing what he was doing and how rewarding it was to him. And I was decent in science, and the University of Nebraska Medical Center was foolish enough to let me in.
Oh, yes.
So that's how I got there. And the governorship of the Nebraska chapter of the American College of Physicians, similar to your position for South Dakota, IR, and all the subspecialties of internal medicine.
Like cardiology, rheumatology,
infectious
disease,
yeah.
Everything.
All represented by the one organization, the largest specialty organization of physicians in the United States. And this is our 100th year anniversary.
Right. This is great. So you're the governor of, and we have a general person who kind of looks over our chapter and your chapter together, Chris Ram, and it's a joy to work with her.
And Kansas chapter as well.
She also coordinates the Kansas chapter. She lives in Sioux Falls. So
you guys brought her to us.
Yes, we
Thank
did.
you very much.
You're very welcome. It's our pleasure because she's a wonderful leader. So now you've practiced, some 30, 35 years in Omaha, and you've changed your role a little bit. What's happening now?
Still practicing general internal medicine, but I also work for Methodist Health System as their chief medical officer, which is sort of the physician representative on the administrative staff of the hospital and the health system.
Yeah, so you're an administrator now. How do you like that?
It's interesting. Physicians always say it sort of with the tone that you said. It always makes me feel a little bad about it. But it gives you an opportunity to look at all the different specialties, what their needs are, what their new procedures and technologies are. So it exposes you to a lot of interesting things in medicine.
So one more step in this whole myriad of opportunities of practicing medicine. I mean, it's part of practicing in a different way.
Exactly.
So in your practice, what would be one of the most challenging things that you've run into? I would almost say diabetes is the hardest thing that I take care of every day, but what would be yours?
Yeah, diabetes would be one of them. I think things like chronic abdominal pain, chronic gastrointestinal complaints, headache, fatigue.
Those are hard ones that you're throwing at.
Those are no fun for us or for the patient who's afflicted by them.
Because we don't have good answers sometimes.
Right.
I mean, every once in a while we have a good answer, and there are certain diseases that we have great answers for, but those are tough ones. I'd like to talk a little bit about diabetes. There's been a lot of changes about diabetes, and I want to throw in think about it now. This is a great time to give us a call. So what about the issue of diabetes and holding off the insulin challenge? staying on orals, keeping from starting insulin. Do you think that we're able to do that more now with the armamentarium that we have, and or are we waiting too long before we start insulin?
I think you're able to do it more effectively than you used to because we have more classes of medicines that we can give to people. However, I would have to say that the primary way to prevent progression in the disease process that requires insulin is exercise, which we were talking about a little bit earlier, and weight loss. I like to tell diabetics that they've got diabetes because of their genes and because of their age and because of their weight, and there's only one of them they can do anything about.
Right. But the problem is I think that it's hard for people to do anything about that one too.
Oh, it's terribly hard.
Yeah. I mean, the New England Journal study says 30% will lose weight with the best methods. After a year, 30% have kept it off of that 30%. And then after 5 years, they're all back to and that's not everybody. I don't think that is a perfect representation of the whole story, but it's certainly one of the biggest challenges.
I like to tell my colleagues that I think it's only somebody with an obsessive compulsive personality that will take weight off and keep it off, like a physician.
Yeah.
I think it's very hard for someone who's not used to exercising and doesn't remember it positively from their youth to make it a habit.
I kind of think that the thing that they really can do, whether they lose weight or not, the huge difference is that exercise component.
Oh, absolutely.
And almost everybody can walk. Yeah. And if you can walk a regular amount every day and gradually increase that distance, get a half an hour anyway for sure every day.
And your glucose tolerance is improved by exercise even if you don't lose weight.
Right.
So you're kind of getting a double dip with exercise.
And not only that, it improves your tone, it helps your heart, helps your lungs, helps your mind, strengthens your bones.
I didn't bring my shoes, or I'd be...
we'd be running right now.
Right.
So it's interesting, when we were in Boston at the meeting 3 weeks ago, tell us about what we did 5:45 in the morning time at our meeting.
Yeah, we ran in Boston. I haven't spent a lot of time in Boston, but we ran down to the finish line of the Boston Marathon, and we did it in honor of Tom Braithwaite, previous governor of the American College of Physicians for South Dakota, who has passed away.
Who's been on this show, a dear friend, terrible loss.
Right.
Makes me feel very sad. Miss him. Diagnosing a medical condition is not always a black and white, yes or no situation. It is often a detective story with several twists and turns and blind alleys. But with proper sleuthing, that includes listening to the patient, success can be attained.
About 6 or 7 years ago, I had a social friend who I noticed that they had a cough at a social engagement, and eventually that led to an office visit. So she'd had it for about 7 years, and the cough had been increasing in severity and had started to interfere with her exercise program. It remained not productive, and it was something that, because of its lifestyle involvement, she'd elected to come and do an appointment. Now, we have a very long list of things that we do with cough. We talk about drugs. There's a drug called lisinopril that causes a cough. We had a evaluation about reflux, and she had some symptoms that suggested reflux. We have asthma symptoms, and we spent some money doing a spirometry, which was perfectly normal. And really didn't get a good handle on the cough on the first visit. I asked her to give me a diary of the cough, see if we could see if there's any pattern. She returned with the diary. Now, it was interesting that the diary said that I cough more in the afternoon. Sometimes I cough in the evening, and rarely I cough at night, and I almost never cough in the morning. She also noted, because we had asked, that she does have occasional burping and belching, so we get a little GI symptom. And this is the time I asked her, well, where's this cough coming from? She said, the cough's coming from right here, and it feels fuzzy. said, that's interesting. I said, do you feel like your throat's closing? She said, I do have a sensation in my throat. I said, well, that's interesting. I think we probably should do some skin testing and see if it's something you're breathing in. She didn't have any dogs or cats, anything like that. There definitely wasn't anything, but since it was during the day and she was going around to friends, maybe there was an association. There was no real reason at that moment to say that we were going to do anything inhalants and do some foods. We thought, maybe foods. So I said, well, is there any other like diarrhea or anything like that? No, there isn't. Any previous issues with food before that you avoid, like spicy foods, that kind of thing? She said, well, yeah, I have modified my diet over the last 7 years. She said, I avoid spicy foods, tomatoes and that kind of thing, because it seems to bother my stomach, which gives us a little hint there's a GI part to what's going on. And then she said, and I've gone a higher protein diet, I eat a lot of tuna fish. Fine. So we sit her down, do skin testing. We include some foods that we include a lot of times, like milk and egg and peanut and soy and walnuts and wheat. But of course I threw tuna on because she said, gee, I'm eating a lot more tuna. And so the skin test came back and she was phenomenally allergic to tuna. And the point here is that allergy is detective work. You never know where it's going to lead you, and you've got to listen closely to what the patient says.
Thank you, Dr. Luzier. That's a great case, and it's a case of the value of taking a careful history and listening to what the patient says. You have any examples or thoughts about where your history has really led you to a kind of a challenging case?
Unfortunately, Rick, I usually find out that my history wasn't good enough when someone else figures it out or the patient tells me what the real cause is. But I do remember one specific highway patrolman in Nebraska who came down to see me with a combination of cough and rash, hives. And he'd had it for years, and we went through the whole differential, never found out what it was. And I'm driving between Omaha and Ainsworth, where my parents lived, and I have a light out, and the highway patrolman stops me in the middle part of the sandhills and recognizes me. And we get to talking. He says, you know, Doc, I moved out of my trailer house and there was a bunch of asbestos in that trailer house when the next inhabitant moved there, and I haven't had a cough or hives since I moved out of that trailer house. And that probably is the most common way I find out. The patient tells me what the allergen was in the case of this patient.
Yeah. Wow. And, you know, cough is such an interesting thing because it can be from so many different things. I mean, you know, it can be a low-grade asthma, it can be an infection, it can be, you know, maybe you're a farmer and there's something in the hog house that's bothering you, or it can be chronic lung disease from smoking. But then there's that heartburn thing where reflux, or even they don't even have heartburn, but when they lay down at night, food rolls up there and it hits that vocal cords and it does. So this one on tuna fish, I've never heard of tuna fish. That was great. Yeah. We've got questions. 73-year-old woman from Iowa following a ruptured Baker's cyst located behind the knee. What are the post symptoms? How long does the pain and swelling last, and what's the treatment? So a Baker's cyst.
So she had it fixed, Rick?
I think she had a ruptured Baker's cyst, and I think it was repaired. Yeah, post-operative. So.
You know, if you repair a Baker's cyst, there's only the postoperative healing pain. She really shouldn't have long-term problems with that. I would guess.
What is a Baker's cyst?
A Baker's cyst is a sort of a hernia of a joint space. People get them in the wrist most commonly, often due to degenerative arthritis. In the case of a Baker's cyst, must have been associated with Baker's kneeling or something at one time, but it's behind the knee. And it's a joint space filled little defect, bleb, on the joint space in the knee. And my experience has been, first of all, that they're mildly symptomatic until they rupture, and then they're very symptomatic for a period of time after they rupture. But unfortunately, they tend to reaccumulate fluid, and the hole that ruptured seals up, and they get recurrent symptoms. So most of the time, they have to have them repaired. And my experience has been it's only been a couple weeks until they
get better.
Well.
Yeah. But if they're there and they're really symptomatic because they're bulging, sometimes you can go tie it off. But the problem is they'll reoccur because it's inflammatory process in the knee. But when they rupture suddenly, they have a hot lower leg, and it can look like an infection, a cellulitis. It can look like a clot, and then it can be a Baker's cyst. That's the differential that's kind of interesting.
Yeah, and if you're not careful, the orthopedist will give them Lovenox or an anticoagulant and make it worse.
Because they think it's a blood clot, and it isn't.
Right.
67-year-old man from Sioux Falls, what are the latest methods of diagnosing and treating pancreatic cancer?
Well, pancreatic cancer is an unfortunate disease. It is somewhat hereditary. There aren't any good screening tests for pancreatic cancer. Almost always when it's discovered, it's either discovered because of abdominal pain and an ultrasound or a CT scan shows a mass. It's only rarely completely resectable for cure at that point. It's one of the places we haven't been successful yet, I would say.
Right, I mean, if you see a skin cancer, you can see it. If you've got a brain tumor or a pancreatic cancer, you don't see it until it's too late sometimes. I think, though, there's new hope because there's been some stuff about injecting cancers with viruses that have been somewhat successful. They're on the cutting edge of working this up, but I'm not knowledgeable about it at this point. And I think you and I both are at this point where we send them off to somebody who really knows.
Exactly.
55-year-old woman from Sioux Falls. I developed severe chest pain requiring hospitalization, IV pain medicines. The diagnosis was doxycycline-induced pericarditis. Please discuss this. Doxycycline-induced pericarditis. Have you ever heard of that?
No.
I have, because this was my case. And let's look at the telestrator here. She developed pericarditis. That, in other words, the lining that goes around the heart swings in this, and I thought that it was doxycycline-induced because I'd started her 2 weeks earlier on doxycycline. The other thing is that I did a level of Coxsackie virus titer, and her Coxsackie titer was elevated. And so it may not have been doxycycline, it may have been a virus-induced pericarditis.
I wonder if the virus titers would change and give you some if you were curious.
Right.
As long as it goes away, you don't care.
Today, I ordered the second set of titers. So you do acute and convalescent. In other words, take it when you've got it. Oh, it's elevated. Now we take it 2 weeks later, and if it's sky high, then we've nailed it. If it hasn't changed, then I'm going to call it doxycycline. So
you can write a paper.
I could write a paper. That's great. Female, her friend who has very cold and red hands and feet. Do the docs know what could be the cause? Red hands, cold hands and feet.
Very common complaint, either blue or red hands, either cold or hot hands, sweaty or dry hands. And I suspect that most of these are related to differences in the autonomic nervous system in various individuals. I think the vast majority of people, it's not a significant issue in their lives. It's more an aggravation than something that's going to be progressive or disabling. There might be occasional rheumatological conditions that might produce the
Raynaud's kind
either Raynaud's or even red rash, especially on the hands, might reflect some collagen vascular disease.
But most of these aren't Raynaud's. They're just autonomic differences in humans, aren't they?
Yeah.
Do you treat these much, or do you do much with them, or what do you do?
Mostly reassurance.
No, don't worry about it. Make sure there's nothing else that's sneaking up on us.
Yeah.
Quick one, 70-year-old woman, Brandon, caller, has a brother with low platelet count, white count of 1. He is a 72-year-old pre-diabetic. He's had a fever of 102 since Sunday. Any ideas of what these symptoms might be doing?
Well, that's a potential serious condition. Why he has 2 of the 3 main components of the bone marrow that are dysfunctional. That can be medication, it can be chronic degenerative processes in the bone marrow, especially somebody 72, myelodysplastic syndrome. It could be even a primary bone marrow problem that is going to require treatment. I think that this person needs a diagnosis. I would think that diabetic is not related to this problem with the bone marrow.
They need, if they're not in with the doctor right now, they need to be there soon. All right, so as we age, the aches and pains of life may require a continuing use of painkillers to help us live the lifestyle we'd like. But those drugs carry new concerns for long-term use.
What's key is trying to find out for each patient what's really going on with them and what their pain problem is, because figuring out the cause of the pain is really important in determining the type of treatment that's going to be appropriate, including pain medications, because they're targeted for different types of pain, whether the pain is related to nerves or muscles. There's different treatment choices. So the assessment is, first of all, is pain present, which can be a real problem with elders that are not able to communicate and report their pain. So finding out if it's there and finding out how bad it is or how severe it is, because that also helps determine the kind of approach that's needed for treatment. And then the quality of pain is what helps us determine if the pain might be from muscles or bones or from nerves. So asking them, describe what your pain feels like. And a common pain from muscle is aching, soreness, but from nerve pain it might be piercing, tingling, burning, stabbing. And so the way that patients describe their pain help us to recognize what might be underlying cause. How do we know when people are hurting that have cognitive impairment, particularly dementia, and can't self-report? And we've put together an approach that can be used. So first of all, of people that have cognitive impairment, mild and moderate, many of them can still report having pain, so we don't discount it. And self-reported pain is always our first line. We want to find out what the patients are experiencing and tell us. But for those that can't self-report, we look at other things, like what diagnoses do they have that we know are painful in people that can tell us. So for example, do they have a history of a fracture? Do they have a history of low back pain? Do they have a history of diabetes that might have led to a neuropathy? So we look to see what's going on with them. What we recommend is if you are suspicious that these behaviors are caused by pain, then treat them as if they're pain and see how the patient responds. So we start with an analgesic trial, low dose. Even acetaminophen has been found to be very helpful in improving pain in that population. So you treat and then you observe to see, are the behaviors any better? You know, do they decrease when we treat the problem and the behaviors if they're pain related? And if they do respond well, then we can move forward assuming, okay, it looks like this is pain. Now, what's going to be the best treatment plan? And that may be drugs, it may be non-drug strategies. We have quite a large array of different things that we can use.
So that's tough. Let's say you have a demented person, who has Alzheimer's disease, and you're trying to figure out what to do to help them. I mean, they can't answer you. They can't give you a good answer. That's a very big challenge. What's your take on that?
Well, I thought she did a great job of explaining it. I think that first of all, if they can't tell you what's bothering them, it's insomnia, it's agitation, it's restlessness that cues you in that something isn't right. If you can't figure out that they, they're constipated, or they have a urinary tract infection, or they got a rash somewhere or something like that, I think her suggestion that you try an analgesic to see if it helps the situation is probably the best course.
Right. I lean on the family a lot because they're hovering and they figure I'm going to have a magical answer and I really know what's happening with the patient. Sometimes I don't, particularly if they're not talking to me. The family, knows that patient is sensing something's different. And
absolutely, yeah.
Family feedback is important. And the nurse who's taking care of that patient in that nursing home, I lean on that person very heavily. It's very important for me to listen to the nursing feedback, or the nurse's aide, or anybody who's inputting that person. So the problem, though, is oftentimes these people are on a lot of medications. What is your thinking about polypharmacy? Do you sense that we're on too many medicines nowadays, and particularly the nursing home patients, or where's your...
Absolutely. I think people come in with complaints, and they and or their family are looking for a solution to that complaint, and you attempt to give them some relief by giving them a medicine, and they may or may not get relief, but they never stop that medicine. And you end up with, honestly, I mean, the screen said 87% of patients over 65, of persons over age 65, take at least one. I would say that's an underestimate in my experience. Yeah, I think the vast majority of nursing home patients, if you periodically did a perusal of their medications and tried to withdraw those that aren't definitely critical, that you would be doing them all a favor.
Yeah, I think we overdo it. But if you're diabetic, you're probably on 2 or 3 pills. And if you've got some heart failure, you're on 3 more. And then, of course, there's all the as-needed medicines that people add. Well, if they're constipated, they can have this, and if they've got,
Yes.
And their list goes too long. Yeah, I agree with you. For pain, there's, people give acetaminophen, which is Tylenol. And now we've learned that there's all these side effects with the nonsteroidals like ibuprofen and naproxen and so on and so forth. So people have turned to using the narcotics more. Is that a good or a bad thing, do you think?
I think you have to be very circumspect with narcotics. What you're looking for is the person functioning at the highest level. And oftentimes in nursing facilities that's not very high, but those people, doesn't take much narcosis to
bring them right down
to the point where they're really not functioning. So I try to find a way to give them some relief and maintain their function so that they can, if they remain ambulatory, they can talk to their families. But you want them to be able to sleep. I think that at nighttime, if they have trouble at night, you really do have to give them something. So yes, I give them something, and I try to give them the lowest dose possible, and I try to stay below the threshold of causing them to be dysfunctional.
And I like to have family members call me on the idea of, can we be on less medicine? And review that periodically. So this is a call out to people who have family members that may be on too many medicines. Talk to your doctor. Say, does he or she really need to be on all these pills? Can you cut them back any? It's amazing. Sometimes when they get sick, they come in the hospital. You take the opportunity to just strip it all the way down to the basics as if you can, and then you send them back on those strip
Right.
level. We have another question, 67-year-old from Sioux Falls. Dizziness when I get up from lying just on my back. Originally started on my left side, but now I can sleep on both right and left sides without a problem. Have been to a doctor who did Epley procedure 3 times, but no correction. Went to a chiropractor 2, still having a problem. Dizziness when they get up. Let's talk about the Epley maneuver. What is it?
Well, I think we have to go back and talk briefly about benign positional vertigo, which is the labyrinthine apparatus inside our head attached to our ears that keeps us in balance as we get older, can get dysfunctional, and it gets dysfunctional because there's a part of it that has to do with not turning but moving that requires a little ball in a sphere, and it gets rusty, and some of the rust gets up in the canals and stimulates the apparatus and makes you feel like you're moving.
So a ball can be in here, right?
So
this is the outer ear. You know, here's your ear. And then this is the tympanic membrane, this is the middle ear, and this is the inner ear. And so the ball can get...
Keep your day job, Doug.
Yeah, I should be. So the ball gets floating around in here, and it's bumping against all these hairs, and you end up in this semicircular canal is causing the problem.
And then the Epley procedure is an attempt to move your head in such a way that you move that ball back into its normal position, and the dizziness is relieved. And that's effective about 85% of the time, but not always. And if it doesn't result in an improvement, you may need to have some more sophisticated testing of your inner ear function to make sure that you made the right diagnosis in the first place.
Right. There's a bunch of other reasons for dizziness too. I mean, the back of the brain, the cerebellum can get messed up, and a variety of other things. But this is one that we can actually fix.
Yeah, and very common.
Yeah, and it's really quite common. I would keep trying the Epley maneuver. I think if you can look it up on the internet, go through it carefully, repeat it exactly as it says. I mean, don't lean on the doctor to do it. Do it yourself. See if you can find, because if it works, it's such a magical thing.
Yeah.
57-year-old woman from Elkton, caller, suffers from benign positional vertigo. Oh, benign paroxysmal positional vertigo. What causes it to occur? What makes the calcium float around the ear? We just talked about that. It's good. We had 2 questions on that. Anything that you want to add on that last one, the benign positional vertigo?
I would say that it tends to go away on its own. It usually only lasts a week or 2 or 3 or whatever, and then it goes away on its own, and it can come back, 6 weeks, 6 months, 6 years later, but a little patience, it'll often go away.
I like the idea of, if the Epley doesn't work, you try to extinct it by sitting on the side of the bed, feet on the ground, lay your head all the way down to the left, wait 5 seconds, sit up again, wait 5 seconds, lay all the way down to the right, wait 5 seconds, and repeat that 5 times, a couple times a day, and sometimes people get relief with that.
Yep.
60-year-old man has been having a hearing loss in one ear. We're doing ears.
That's all right.
Over the last couple of years, I've seen a rapid loss to the point that I can almost hear nothing out of it. It feels full, and I have felt that there is an infection because it's producing a mild, small amount of oil-type substance out of that ear. I've told my GP about this. He says that there's no infection, orders an ear wash. This does nothing. Is there anything or anybody that I do to stop and fix this problem?
Well, if indeed you almost have no hearing in that ear, it's not likely to be an obstructive process in the canal or even fluid behind the drum. If the hearing is almost completely gone, there's probably a nerve problem, and a little testing might find the cause of the hearing. Unfortunately, oftentimes that fairly rapid loss of hearing is not easily corrected, but it'd be a good idea to know for sure what it is. Though.
Right. I think that's the time to go to the ENT. You've been to your primary care doc. Ask him in this case, to send you to ears, nose, and throat specialist. You can test it by putting a tuning fork on your head, and if you hear it louder on that side, that means that is something you could do. If you hear it less on that side, then it's that nerve loss.
That's right.
So get a tuning fork. Here's a
Only
drawing.
Dr. Holman, myself, even remember how to do that.
A tuning fork. You got to be graduate of the School of Medicine in we don't want to say. So here's a picture of an ear.
Yeah.
You want to draw anything? Does that give you any picture? It doesn't have
it doesn't have the semicircular canals, but this is the.
Yeah, do that.
That's the eardrum right here. Fluid behind the eardrum. So this is where wax would be. And the eardrum can have a hole in it, or it can be stiff because the bones get calcified behind it, or there can be fluid behind the eardrum that reduces its function.
And that's the eustachian tube.
Yeah,
Exactly. What's that?
So the eustachian tube empties from both ears up above the soft palate, which is the top of your inside of your mouth, and equalizes the pressure. It's what occurs on airplanes. If your eustachian tube is not wide open, then you get pressure problems when you go up in an airplane or up in the mountains. That can also produce some hearing loss because of eustachian tube dysfunction. Usually, though, that's transitory and can be helped, by trying to equalize the pressure like you do in the airplane.
Or yawn, that type of.
Or yawn.
Well, where's the eustachian tube here? That's this right here.
You mean this?
Yeah.
Yeah. It's connected to the middle ear, which is right behind the eardrum.
Right.
Yeah.
Right. Okay. There is, and I sometimes people get the wax out of their ears, and suddenly the problem, a lot of problem goes away. But it isn't generally no hearing.
Yeah.
Yeah. There's something else happening. Female, methyl N-tetrahydrofolate reductase, MTHFR. Are the doctors familiar with this, and do they have an opinion as to whether a patient should undergo the testing for it?
Well, that's an enzyme defect that's familial that increases your chance slightly of getting blood clots. I think it also interferes with your chances of having a successful pregnancy, if I'm not mistaken. This is Rick, Dr. Holm may know more about this than I do. This is kind of out of, as I was telling Rick earlier, the average age of my patient is 77 now. I don't see many people who are afflicted by this particular problem.
I don't either, and it amazes me that you knew this, because I didn't know that one. But it certainly, if they are trying to have a pregnancy, there's some blood thinner kind of treatments that people can be on.
And if they've had clots, this is one of the hereditary defects that people look for to see if you're predisposed. Any supplements, as long as we're talking, let's see, where are we got? We've got more questions. Let's just run through these questions quickly. Via email, I do not smell anything, even a skunk. I wonder if I could do something to help. I think some of that might be, certainly allergic things, and I like the idea of an antihistamine and a steroid nasal spray, nasal quart and Allegra, and put that combination together and get off of zinc. I had a guy come in who was taking zinc supplement, and he was losing his smell, and I had him stop the zinc, and his smell came back. Had you ever heard that one? No.
All right.
I won't forget it.
Make sure that you're off the zinc supplement. I had shingles on my eye last year at 40 years old. Look at your, by the way, look at your multiple vitamin. And I dumped that right now. Just no supplements for a while, and see if your smell comes back. I had shingles on my eye last year at 40 years of age. I know they recommend the vaccine at 50. Should I get the shot early since I got the virus so young? What's your take on the shingles vaccine?
Well, we used to think that the shingles vaccine was a lifetime immunity. It now turns out that it's probably, maybe 6, 8, 10 years of immunity effectively. So if you've had shingles, you can expect to have a fairly robust immunity for maybe a half a dozen years. So I don't think it matters when you take the shot from the standpoint of getting adequate immunity for those 6 or 8 years, but probably, I'm guessing in the future, the recommendation will be that you get it repeated more than once during your life. And now the most cost-effective time is in your early 60s to get it, because that covers, it gets more and more frequent and more severe as we get older.
Well, and painful.
And painful. If I was this woman, I would wait a half a dozen years, and then I would get another. Then I would get a Zostavax, the shingles vaccine. I'm not sure that that's etched in stone as a recommendation, though. I'd be interested to hear what Dr. Holmes says about that.
I agree with that, although I know that they're saying more and more as you're younger. But the problems arise when you're older, and that's why I think at 60 she should definitely do it. But she had it in her eye.
Oh, it's bad luck.
I would say maybe I'd get it at 50 and get it at 60. I mean, what's the $200? And maybe your insurance would cover it, but I'd do it.
Her insurance might at 50.
Yeah. Okay. What is proctalgia fugax? And
is this a patient? How did they know that? Proctalgia fugax is rectal pain, usually occurs at night, very severe. Goes away spontaneously. You can sometimes get it to go away if you sit in some warm water. It's a pelvic muscle spasm is the way I understand it, and doesn't require any treatment. I can't remember if there's any. I think pretty much by the time you access any treatment that would be effective, it would probably have dissipated. But
yeah, well, I get leg cramps periodically in the night in the calves. You know, they go into spasm, and the moment I can feel it coming on, I stretch it. The problem is I can't figure out how to stretch that rectum, though, except maybe have a bowel movement. I don't know. Good idea. I wouldn't put my finger up there. I guess
it is well established. It's not rare, but it's not common.
Yeah, I think sitting in hot water or taking a hot shower might be a good idea, or cold. Maybe cold takes the spasm. 79-year-old Rapid City was just diagnosed with pulmonary fibrosis. In July, they do another CAT scan to determine the prognosis. What can she expect if the prognosis is poor?
There are several different kinds of pulmonary fibrosis. I'm guessing this is primary pulmonary fibrosis that you're describing. It is variably progressive, but tends to be progressive and can, in the long term, have a poor prognosis. However, there are just recently some new medications that have been shown to be effective by reducing the tendency for more scar tissue, more fibrosis to occur in the lungs. So I think there's a little bit of light at the end of the tunnel for people who have pulmonary fibrosis. Ultimately, a younger person might end up with a lung transplant. At 70, you know, that would be a hard decision to make.
But, you know, this is commonly called idiopathic because we have no idea why it's occurring. Right. And, you know, in 20 or 30 or 40 years, they may say, oh, well, all along we knew it was a fungus, and here's the treatment. Or all along it is an immune system thing. We treat it with this, you know, the immunotherapy. But we don't know what it is right now.
Yeah.
Yeah, and I think what you said was very important. This person is going to have an estimate of this fibrosis getting worse by how bad it changes. And then they're going to say, well, this is your course, and there's nothing we can do. And I would say this. It's variable. We don't know for sure. Yeah. So I think I would follow what the pulmonologist said. I would definitely, you know, he or she may put you on a steroid.
Well, and I think they may. A pulmonary person, if it looks to be progressive, they may put you on a new treatment that may be effective.
Right. There's new things. 88-year-old woman from Watertown has had 2 knee replacements 12 and 15 years ago. Knees are very achy. Will cortisone shots help? Anything else to do to alleviate the pain?
I think Rick had, must have been, was it last week or last month, 2 orthopedists on, and one of the orthopedists I thought handled this particular question very well. And I think the secret is to figure out why the knees hurt. Is it a knee replacement that is worn out?
It needs a plastic replacement.
The plastic needs to be replaced. Is it some sort of tendonitis that could be treated in some other way? Is it an infection? This would be rare at this time frame that it would be an infection. And those orthopedists, when they have a foreign body in a joint, they're very hesitant to give cortisone shots.
Right. I think I think that we probably don't do enough cortisone shots for osteoarthritis in the elderly. I think we could do more of them in a plain old osteoarthritis. If there's been a knee replacement, I never inject. Do you?
No.
No. Via email, I have a fatty tumor about the size of a silver dollar. Sometimes it's very painful, most of the time not. What would be the downside of having it removed? Quick answer.
Nothing.
No downside.
No downside.
But I've got a functional fatty tumor on my back. You know what a functional fatty tumor is?
No, I don't.
It's a fatty tumor that I use to teach everybody who has a fatty tumor that it isn't anything to worry about, and I generally leave it alone. What is the prognosis of glioblastoma multiforme tumors? So why is it so poor?
I do not know why it's poor, but it is poor. And this kind of goes back to the pulmonary fibrosis thing. There are new treatments being attempted for glioblastoma.
Polio injections, in fact.
All kinds of things. And hopefully we'll soon find something that is significantly effective. I mean, we have some things that help a little bit, and obviously you usually end up with a resection and some radiation therapy, but that's about all I know.
We're on the cutting edge because there's some new things. I mean, I had a head and neck guy come in, and he was just thrilled because they're injecting malignant tumors that are metastatic from head and neck with certain viruses and seeing cures. 79-year-old male, soft lump inside the throat that looks like a popcorn cottage cheese. Can remove it and it comes back. Has heard of tonsil stones but not sure what it is. Seen an internist want to remove tonsils but he didn't let them. What's your opinion? So he's got crypts. He's got this crypts on the tonsillar. What's your take on this?
I had these when I was younger. They give you bad breath sometimes, but otherwise I don't think they have any significance. Sometimes you can, if you have one of those things that shoots water to help clean your teeth out, you can sometimes evacuate the crypts with a little water gun.
Okay, real quickly, I have a great deal of pain due to spinal stenosis, arthritis. My GP prescribed naproxen. I'm starting taking one in the morning, one at bedtime. It's given me relief where other meds did not. I'm certain about side effects. Thoughts? There's a lot of side effects with naproxen, burning holes in the stomach, hypertension, but it can give some great relief.
Kidney disease, and you protect your stomach and you monitor your renal function.
Very good. We'll be right back after this.
When you quit smoking, you get extra cash in your pocket right away.
Yeah.
1 month and you've got $150 extra you didn't have before. Quit 6 months and you have an extra $1,000.
Oh.
$2 grand in a year, $4 grand over 2 years, and a whopping $10,000 in 5 years. Nice chunk of change. So take a deep breath. You can do this. We can help.
There's probably no more urgent diagnosis in general medicine than when people are having trouble catching their breath. This accounts for about 5% of all emergency room visits and about 50% of all admissions to the hospital. Most challenging is that breathlessness may be anywhere from a low-risk problem to one life-threatening. He came into the emergency room with the feeling of impending doom, chest pressure radiating into his neck, down his left arm, and he couldn't catch his breath. The blood clot in his coronary artery was diagnosed by history with a little help from an electrocardiogram, and his breath came back after a clot-busting IV drug. The college student came to the emergency room dramatically short of breath and had a normal lung exam, chest x-ray, and blood tests. She was emotionally overwhelmed by impending finals, and when we walked her in the hall, she felt better and her breathing calmed down. The trucker had noticed his legs swelling for a week, and now he couldn't catch his breath. The life-threatening pulmonary emboli, or blood clots from leg to lung, were proven by lung CAT scan and effectively treated with anticoagulation. The young woman had a remarkable pale white face and was extremely short of breath. Profound anemia was proven by blood test and leukemia by bone marrow test. She lives a normal life now 20 years after her bone marrow transplant. The 12-year-old struggled with deep and rapid breathing. The air around her smelled fruity. Her lungs sounded clear by stethoscope. The blood test found high blood sugar, and her blood test for acid was high. Diabetic ketoacidosis was resolved over 8 hours with insulin, and her breathlessness went away. The 70-year-old lifetime smoker came down with influenza given to him by his 4-year-old non-immunized grandson, and his usual breathlessness occurring with any exertion worsened to the point that he was breathless just laying there. He died after 3 weeks of intensive care, steroids, antibiotics, even being placed on a respirator. I was a grade school kid having difficulty breathing and sleeping at night as the blossoming tree pollen blew across my bed. It was my prairie doctor from De Smet who heard my story, listened to my heart and lungs, correctly diagnosed asthma, and provided the inhaler medicine that gratefully allowed me to sleep. The causes for breathlessness span almost all the organ systems of the body. One symptom potentially due to many problems. If you can't get your breath, you need to get some help. Believe it or not, On Call with the Prairie Doc has been broadcast for 13 seasons on South Dakota Public TV. We still have 3 new shows for this season, and then the best of On Call with the Prairie Doc encore presentations begin for the summer. We have a busy off-season plan that we hope will improve our show for season 14, which begins in late August. Thank you for watching On Call with the Prairie Doc. We hope that tonight's episode and every episode empowers you to work with your medical providers to better manage your health care. You are the most important player in your own personal health management, and maybe that is ultimately the best takeaway for everyone each week. From all of us here at On Call with the Prairie Doc, until next time, stay healthy out there, people.
The difference among prescription medicine, over-the-counter treatments, and supplements. Do they work or are they a fraud? Supplements, facts, and fiction. Next time on Call with the Prairie Doc.
Funding for On Call with the Prairie Doc is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call Television as it continues to open doors for important medical information.
And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota.
Additional funding is provided by
Aberdeen Asthma and Allergy,
Brookings Health System,
Dakota Allergy and Asthma,
Dakota Care,
Dakota Dermatology,
the Orthopedic Institute,
Physicians Care Sanford Clinic Community Service Committee,
and Swiftel Communications.
Closed captioning for On Call with the Prairie Doc is provided by the generous support of
Avera
Brookings Health System
and Fishback Financial Corporation.
Hello and welcome to On Call After Hours, where we answer the questions we weren't able to get to during the broadcast portion of our show. All of your questions are important to us, and we want to answer as many as we can for you. So here we go. This is a male, has a severe allergy to corn. Do the docs know of a treatment for osteoporosis that's not corn-based? Have you heard that corn-based osteoporosis treatment?
Well, I haven't heard of any that were corn-based, to tell you the truth.
Yeah, I didn't know that they were.
I think most of the medications that we give are not corn-based.
Fosamax corn-based?
I don't think so.
Well,
Prolia?
Yeah, no. Prolia. Don't think Prolia is.
Vitamin D?
Yeah, I prescribe vitamin D, sometimes calcium supplements, but mostly just vitamin D and exercise. I've really not been quick to use the Fosamax and those meds.
And when I think that if you don't actually have osteoporosis or a fracture that you didn't deserve, you probably shouldn't. I think it's overdone.
Yeah, I think it's overdone. 64-year-old woman, right hip aches at night, not during activity. Also, on occasion, have a pulsing pain down the front of the right leg while laying down. What could be causing the pulsating pain and the right hip pain? That's very interesting. Right hip aches at night, not during activity. Do you have any idea? I wish I had the orthopedist from last week on.
Yeah, I think that person probably needs a brief examination.
Yeah, needs to go. You know that I think that it's sort of like a ligamentous or a meniscal thing. Sometimes it's worse laying down. I don't have a good answer. Do you?
No, not yet.
We'll find it.
We'll get her on examination.
71-year-old woman cannot be in the sun for more than 10 minutes. Will start burning skin after a while. Will develop severe headaches, nausea, fever. It's been going on for 25 years. Had chemo in '86. Does he have anything to do with the sun?
I hope you know the answer to this.
Well, I'm thinking lupus. You know, I worry about solar sensitivity and hypersensitivity. And it may not be any of that. I mean, there's also porphyria kind of things.
Yeah, but that's not a, I mean, that would be more chronic. She would have that even if she wasn't out in the sun on a chronic basis.
Yeah,
so you may be right. It could be a
lupus. Go to your doctor and throw that question at her or him and see what they say. 57-year-old diagnosed with pulmonary hypertension recently, referred to cardiologist for follow-up. Appointment is 5 weeks out. What can be done for symptoms of exhaustion until seen by a cardiologist?
Yeah, this problem, pulmonary hypertension, assuming this is primary pulmonary hypertension as opposed to some secondary problem due to cardiac valvular disease or something, used to be a really serious therapeutic problem. It has now become much easier to treat, several different agents that are useful, but I don't think there's anything that she can do, or he. I assume it's probably
a she.
I don't think there's anything that she can do until she sees a cardiologist, but I do think that 5 weeks out for an appointment if you're symptomatic is probably too long.
Yeah, push your doctor to get you to the cardiologist sooner. Or, and I don't know if getting started on sildenafil 20 milligrams once or twice a day is something that your primary care could do. I don't
I don't have enough experience, I would say, for myself.
Sildenafil is Viagra. And what they're doing is there's a generic Viagra called sildenafil, and they can bring it to you at 20 milligrams dose. Personally, I'm using generic sildenafil 20 milligrams. It's been used for pulmonary hypertension for guys who are looking for erectile dysfunction, you know, because it's a cheaper option. But pulmonary hypertension, sildenafil, you know, and ask your primary doctor to help you or get you in sooner, I think.
Yeah.
71-year-old woman from Watertown wondering, there are any effective treatments for osteoporosis? We just talked about it.
Several effective treatments.
Yeah, but exercise is the most important. 76-year-old woman with Yankton would like to know what the docs think of people over the age of 75 taking cholesterol-lowering medicine, or do they have an age at which they should quit taking cholesterol-lowering medicine? We may disagree on this one.
If there's a good reason to take it and your life expectancy is more than 2 or 3 years, there has been shown to be a reduction in cardiac and cerebral vascular endpoints if you take lipid-lowering therapy. I think I might say the new 75 could be the old 55 in a way. If somebody had a serious problem, either with risk factors or previous vascular disease, I wouldn't hesitate to give it to them, at least to see whether they tolerated it okay. Are you going to argue with me?
I am. Because as you get older, the side effects certainly go up on the lipid-lowering drugs. And my comment is those numbers have been greatly expanded by the people selling the drugs.
Oh, that's for sure.
I think the difference, you know, if you haven't had an event, it's like...
You're not 75 yet. That's your
problem. When I get to But if you've had a heart attack or you've had a stroke, okay, maybe. But you have to treat 28 people before one has benefited.
Yeah.
And the risks are significant. You know, memory loss being one of them.
Yeah.
So get exercising. Get out of your couch. That's way more important.
Well,
a glass of wine probably is way more important.
Yes.
Unless you have an alcohol problem.
Yes.
You agree?
I agree, but you could do both of those things.
Yes, you could. All right. 71-year-old female from Platte would like some information on the sciatic nerve disorders associated with it. Has been to docs and chiropractors and PT, and it still gives her pain in the upper buttocks down the lower leg.
If it's really a sciatic problem, which generally means that you have a compression of the sciatic problem, there are very few things that you can do outside of the body to make it go away. So If indeed you can prove that you have a compression neuropathy, either it goes away with time or you have to remove the compression in some way.
Yeah. You know, that's a tough one because back pain, surgery to take away pain doesn't always work, but it sometimes does. And like 80% of people who've had back pain who have surgery will get relief. 80% of people who don't have surgery will get relief, you know, but sometimes...
And I think that the cue is, if what you have is back pain, then Dr. Holmes is exactly right. You don't do surgery for back pain if you can avoid it. If you actually have radicular pain or sciatica, your chances of it getting better are much greater than if your primary problem is in your back.
And if you start to lose function in that leg, your foot's dropping or you're losing muscle strength,
yes,
then you need to have surgery. I mean, those are times when you really do move on that, right?
Yep.
You agree? 64-year-old male from Huron, severe case of lymphedema with a lot of discharge, is morbid obese, lots of itching and burning. Personal doc tells him to lose weight. He knows he should, but in the meantime, do docs know any ways to relieve the pain and burning?
Well, you could have a complication of the lymphedema if you have cellulitis. You may need antibiotic treatment. Compression is not as effective for lymphedema as it is for the edema that we get from just retaining
But
fluids.
I think this isn't lymphedema because he's got drainage.
Yeah,
He's got discharge.
and that may be a misnomer, in which case if it's not lymphedema but regular accumulation of fluid, then it's compression.
And elevation.
Yeah.
If you elevated that leg above the level of your heart and you compressed it with an ACE wrap or a support hose like 18 to 22 pound to the knee, that'll bring it down.
Absolutely.
And then your wound can heal and the drainage would stop. That's a big problem. I deal with so much of this.
Yeah, lots.
Lots of it. 75-year-old male from Pierre has been hearing loss and severe tinnitus, struggles to sleep, participate in normal conversations. Does the docs know any way to manage tinnitus?
Easy answer, no. I've had it for 30 years.
And I see you have hearing aids.
And I have hearing aids, which goes along with tinnitus usually, high-frequency hearing loss.
Did you have noise exposure that did this, or is it inherited?
Both. I don't believe there's a good treatment for tinnitus. Do you know of a good treatment for tinnitus?
Turn on the radio and then turn it to off the channel and listen to the and then let that help you, or wave machines, or in other words, cover up. There's no good treatment. Nothing. Yeah. It's nerve loss.
Yep.
Yeah. Is there any help for people with IgG4?
I don't know enough about that to answer the question.
You know, I don't either. I would say immunodeficiency and need IG shots, you know, and I just don't know enough.
I don't either.
And here's our last question. 44-year-old female from Sioux Falls with many conditions, most autoimmune in nature. Her AMA is 1280, now presenting with Crohn's or colitis. Can the digestive issues cause all of the other autoimmune symptoms? Could lupus cause a variety of autoimmune symptoms? So she's got autoimmune in nature. I don't know what the AMA is.
That's probably anti-mitochondrial antibody, which goes along with some of the inflammatory bowel diseases and hepatitis, autoimmune hepatitis.
And the digestive issues cause all the others. I think they run together, don't they? Yeah. I mean, it's like, it's a myriad of diseases. It's sort of like a rainbow kinds of things. Could lupus be a cause? Yeah.
Yep.
Anti-nuclear antibody, ANA, and then anti-mitochondrial is related.
Yep.
Bill, I can't tell you how much I appreciate you coming all the way from Omaha. I'm going to give you twice as much money as I get for doing this. Thank you so much.
It's a deal. Thank you, Rick.
Thank you for joining us on our website. We appreciate all of your questions and the opportunities to answer them. Until next time, stay healthy out there, people. Yeah, and I will.
Why did you start?
It was a radio show, and it was such it was helping people. You know, I spend my whole day doing one-on-one.
One at a time, yeah.
Why not make it a broader deal, you know? And then the radio show is, opportunity to do a TV show, so we jumped in and we did it. I mean, actually, I tried a TV show like 20 years ago, and then